Okay, welcome and thanks for joining us. My name is Stacey Davidson from eMugs, and this session has been brought to us by our friends at Butterfly. In this session, Dr. John O'Henry will be talking with Dr. Michael Ayling about his experience as both a COVID-19 patient and clinician, and how he used his Butterfly device and point-of-care ultrasound at this time. So let me introduce Michael and Jono to you. Dr. Jonathan Henry is a stray Kiwi emergency physician based in Victoria, Australia. His special interests include cardiac and lung ultrasound in the critically ill and the use of point-of-care ultrasound in resource-limited settings. Dr. Michael Ayling is a specialist anaesthetist in the southwest Sydney area. Michael completed FANZA in 2008 and was formerly a regular Army medical officer prior to anaesthetics training. So Michael has always had an interest in anaesthesia and remote or unusual circumstances. So welcome, Jono and Michael. Great to have you with us. And I'm now going to hand over to Jono and I'll chat to you briefly at the end.
Yes, thank you so much, Stacey. So look, it's been great to meet you, Michael, and I'm really looking forward to today's discussion about this pretty unique experience you've had early on in the pandemic, really, first as a patient and then as a clinician using point-of-care ultrasound in examination of COVID patients. You're over there in Sydney today, is that right?
Yeah. I live up in the Southern Highlands. About an hour out of Sydney, so I have a long commute each time. So I work up in Bowral and also mostly in Campbelltown and Liverpool in hospital in southwest Sydney area. That's where I trained.
Great. Well, I'm here in Melbourne, so well, sadly, I guess our two states have had the most COVID floating around thus far.
Yeah.
You know, I thought maybe we could start today. What if you talk to us about where you were in your ultrasound journey before this whole pandemic hit?
Yeah, so in 2019, my dad always had an interest in ultrasound because we used them for vascular access and nerve blocks primarily on our regular practice in anaesthetics. But then these new handhelds started coming on the market, and I'd seen some of them. A lot of them were quite expensive, and the cheaper one came out, which was the Butterfly. And I thought, well, for me, it was discretionary money, so I just bought one. And then I had to justify having bought it. So then when we did a POCUS cardiac ultrasound course, and
how long ago was this?
This was November 2019. I did that course.
Wow, so this was really just leading up in the months prior. You hadn't had a lot of ultrasound use until
not all the time. I mean, a number of my colleagues, and we bought these handheld devices in order to force us to use them more, because as I was leaving anaesthetic training in 2008, and then I went off to Wagga for a couple of years and everything. In the year that followed that, there was a tsunami of interest in ultrasound at Liverpool Hospital, where I did my anaesthetic training, and they had ultrasound fellows, and everything was ultrasound, and everything's really scanning anything that moved or didn't. And it felt that, and also some of my older colleagues felt that we were in danger of missing that boat and falling behind. And so I bought the Butterfly to force myself to well, really because of the sunk cost fallacy, but you know, to force myself to use it, having spent the money. And so then when having done that, you realize that there's so much more potential, and why wasn't I using it so much more before that? I mean, before then I'd be doing nerve blocks with stimulocators on the nerves, looking for the biceps contraction and that sort of thing. And you go through a transition, you'll end up doing you use the ultrasound, but you'll still keep the stimulator just in case. But that mindset of that is really like using a non-invasive blood pressure to confirm your arterial line. It's rubbish, but it's sort of moving from one level of comfort to a different level of comfort. And now, of course, we have the nerve block needles that don't even have a wire on them, so there's no pretense of even using a stimulator. So I bought it to do that. They did the cardiac course. To be honest, I don't use the handheld, the pocket ultrasound very much for cardiac because of the footprint size, and none of the models of all the different brands have a very good resolution for anything other than the most basic qualitative study, which has its merits. I mean, it's nice to know if there's a pericardial tamponade or if the heart is beating or it's not beating during an arrest. You can see quite some useful information, but. And then after I did the echo, the basic focus cardiac echo course, I took advantage of the government's tax laws. This is pre-pandemic, where you had a $30,000 instant write-off. So I bought a Mindray M8 machine and some transducers. So I spent a lot of money on that and claimed it all in that one tax year. So it made it easy to do. Then enrolled in the Australasian Society of Ultrasound Medicine Rapid Echo certificate clinician perform ultrasound. So echo training in Australia, as you probably know, is still evolving. You've got a 30 scan course like in the RCE CCPU, or a 725 scan course in the DDU, and nothing in between. And so I had all these lofty plans to do the critical care DDU, and then some intensive care specialists talked me out of it, essentially because getting access to an echo lab, a lot of the cardiologists are paranoid that you're going to suddenly set up an echo lab and take their work from them, as if I want to do that. But, so that's another aside from this talk, but it would be interesting if anyone from ASM is listening to this, if there were a course similar to the British BSc course, which is 250 scans or something, that will be much more useful for ED and for less regular scanners to have something a bit more concrete. Anyway, so I did that, and then I started looking at different modes of scanning. I started doing gastric ultrasounds, which I do quite a lot of now when there's uncertain fasting status. And I moved into lung ultrasounds just for people in cardiac failure. And then this
is before the pandemic. You were starting to get a bit of lung experience.
All through 2020, I started doing a few lung scans on patients. I thought I'll try and incorporate it in some of my ward pre-anesthetic consults for patients who had some degree of cardiac failure or lung pathology. And there is a respiratory physician at my hospital who has an interest in ultrasound, and so she's been sort of coaching me along. So I didn't get a chance to do a formal course, and I would have liked to, but then the pandemic hit and everything shut down, and we couldn't travel anywhere. And a lot of us are concerned if we do travel somewhere, that particularly if it's Queensland, that anaesthesia will shut the borders, and then you get trapped. I mean, I could think of worse things than being trapped in Noosa, but still. So then I hadn't had a chance to do a formal lung course. So then the pandemic hit, and I ended up setting up my machine with one of those plastic covers that you go over that you fit over a II in Echo So I completely encased my machine. I was listening quite a lot to the Ultrasound podcast, which is run by some emergency medicine physicians in the US. And that's been a really good resource, actually, just for practical things like cleaning things and different angles for your probe. And I actually got a couple of nerve block ideas from that as well, And so I looked at that, and then I bought a curvy linear probe, with the intention of potentially using that. So I did do a series of scans on some patients with COVID. We didn't get a lot in the first wave of the Wuhan strain. And most of them were from one cruise ship. And so I found one patient and managed to scan him at several weeks, 3 times over several weeks intervals, and showed his change in scans. And we just beat the rush of those, what essentially were a lot of look what I found studies in a lot of the journals. So like, here's a COVID patient, and here's some scans of it, which were, when they came out of Bergamo, and Wuhan, they were very interesting because nobody had seen them. And then everyone's like, okay, another study with some scans in it, you're not getting published. So we didn't get that published. So I got more experience doing that. And then things died down. And so I started just wheeling my machine around for consults. And then I found myself using the big machine less and less because I just had my Butterfly in my backpack. And so I got a RAM mount with a claw on it, and one of those one of these quad lock things on the phone. So then I've got that, the other side of that on the mount. So I just put it onto a bed rail or a drip stand, and I have it in my bag. So if I have one go at a vessel and it's not really, and I know it's not just a fluky bad go, and so it's got quite, a really fat arm or fluid in the arm, I just go straight for the ultrasound, and the patient has less trauma, and you got a higher success rate. So I had, some sterile probe covers and the butterfly in my bag for that. So then in July, Delta hit, and I found myself using my ultrasound maybe twice a day, every day, and more often than not, it was just for vascular access. And so then the 15th of July, I was waiting in my anaesthetic department common room and for someone to finish the morning list. And so he came out, and we were in a room about 10 meters by 5 meters. He came in. I had a cup of tea in my hand, so my chin around my mask around my chin. And in any case, it was a level 2 mask, so just quietly, they don't do anything anyway. So not the level 2s, I mean the N95s do. But so the other consultant came into the department, had his mask on, but it too was a level 2 with ear loops, so not very useful. Said, sorry, my list ran over. And then he left the room. It was after about 30 seconds. And then I stayed in that room for about 10 minutes. Then I went into his theatre. Now, because it wasn't an MRSA case, that theatre had not been terminal cleaned, as they call it, with bleach and everything. So he had shed saliva and whatnot around the benches, the knobs, the buttons, So in the anaesthetic bay, which doesn't have laminar flow like the operating theatre, there was a potential for a latent virus in the anaesthetic bay. Earlier that morning, he had developed sneezing. I mean, we'd already been vaccinated in February, March in Pfizer. So this is July now. And he developed sneezing.
This is July of this year.
Yeah. So Michael, he developed sneezing at about 10 o'clock. And then when his lunch arrived at 2 o'clock, he couldn't smell it and had enough presence of mind to go straight down to the flu clinic and get tested. So I worked that whole afternoon, and about 30 people were sent home as close contacts for 2 weeks. So the hospital, the anaesthetic department really suffered for that. I'm the only one that caught it. I'm also about 15 years older than most of everyone else he came in contact with. So I'm 48 now. So these registrars in their late 20s, early 30s, and even younger nurses. I suspect that's one of the reasons why. Or at least those in the operating theatre who had a similar amount of contact. And there were registrars who he had sat down with that afternoon and had long talks about it, because he's a supervisor of training. They didn't get it.
Wow.
So, I mean, that shows that for all of the propaganda out there, that, transmissibility does seem to be reduced by the Pfizer vaccine, of Delta at least. So the next morning I got a phone call saying, don't come to work. So then I said to the rest of the family, look, we don't have an air-gapped granny flat. All this business about isolating in a different room in the house is rubbish, which I gathered from my nuclear, biological, chemical warfare training in the army. Unless if you go into, like, if you get emergency department and you get someone who's had organophosphates and someone shuts the door to resus, and I just point up at the vents and say, this is rubbish. If you're going to isolate them, you need an inner and outer cordon, that you need to do it outside, and do it or don't do it. Like, it's a Yoda plan. There's no just making an effort and being seen to make an effort. So I said, look, sorry, you're invited to my POCUS party. So, and that wasn't the intention to give it. I just knew that it was not going to work. So we all isolated as a family. And so then the Sunday, my wife had been vaccinated. My children were fairly young. Sunday morning, so this is on day 3, I woke up at 6 in the morning, which is not common for a Sunday. On my side, in a spiritual rate above 30, and my SATs were 94%. And I have a lot of gear at home because I do a dental sedation list. So the nurses were happy with me whenever they rang me up. I had obs for them. So then I got up around about after an hour, the shortness of breath settled. I still had quite intense congestion, and mostly on the right from the sleeping side, and associated tinnitus. So then I got tested and was positive, and so we all stayed home, or we were still home anyway. The interesting thing about that was, because I live in a a semi-rural area, the community, last year there was another family in a similar suburb near ours who got it, and they didn't know they had it, and so they went on a Bilbo Baggins adventure around town with the virus, and we ended up with, you know, virtual pitchfork, people chucking rocks at their house, you know, and telling, get out of our town, don't you bring the plague to us. So my concern was, as soon as our chief health officer went on TV and said Barradoo, which is my suburb, I went, oh God. So all the Bogans and Karens in Facebook just fired up trying to work out who we were. So I got a local GP who does the radio interviews on COVID to put out a press release, and it let them know that we'd be in isolation for 3 days before I was symptomatic, and then it all died down, and they didn't care about us, they just cared about whether we were going to give it to them. So and so then we went to the, you know, like anyone else who's been in isolation, with food being delivered, and step away from the door, please, I will come to you. They come to give you something, no, step away from the door. You know, and police were coming around to our house to make sure we weren't leaving. So I had to spray down my passports and put them on there for the police to check the kids' identity. So that was on a Sunday. So by Tuesday, so my wife and kids all tested negative. And then they didn't believe my wife's, because one of the levels was officially negative, but was just not, frankly, not believed, because it was close to equivocal. So we did it again on a Monday and she was negative. Did another test on the Tuesday, she was positive, and my eldest daughter, who's 14, was positive. My youngest two, 10 and 12, were negative at that stage. So I found the following day, I woke up, I had Drixine. So the following day, the Drixine wore off at about 4 in the morning, and I woke up with congestion. So I sat up the rest of the morning fighting on Twitter or whatever else, and didn't get short of breath. And again, I just slept upright on 3 pillows because of the congestion, and didn't get short of breath. And what we've been finding with the hospital and the home care is that people are getting early morning shortness of breath, and then it wears off after they get up. And I presume that, you know, if there's VQ mismatching, that's being improved when they've changed their posture, and that. And obviously that's one of the reasons why proning, which we'll go into later, tends to help them, because you're redistributing to decrease the shunt. So on about day 4, I think that's when I lost my test. Day 4 or 5, I think day 3, I lost the sense of smell, but I didn't know. And this is quite a bit weird, because I'd let off some processed food in the atmosphere the evening before. My wife said, that's dreadful. And I said, oh, it must have worn off. Oh no, she did. She said, I'm sorry, I farted. And I said, oh, that's all right, it must have worn off. And she said, I can still smell it. And so I went, oh, well, I must have blown away. So then the next day in the evening, we were cooking some food that my mother-in-law dropped around. And my daughter said, gee, that chicken pie smells nice. I said, well, does it? It doesn't smell at all. And then I put my nose into a tin of ground coffee, and there's nothing. So that was quite interesting, that we don't rely on the smell as much as some other species do. So I found myself putting habanero chili sauce on all my food to try to taste it, and all I did was just get burning on my lips. Wow. So that went away, and that went away from my wife and my daughter. My wife only got urty symptoms, just a runny nose, and not much of a cough. None of us got much of a cough. None of us had a fever, and the fever hasn't been really a feature of Delta so much as it was for Wuhan strain. It's where they stopped measuring them when we walk into the hospitals now. My daughter has a background of mild asthma. So she got some shortness, she got some wheezing on her day 1. And then the next day, as soon as I isolated, I started her on fluticasone, which we had in the drawer. And then as soon as she became positive, I switched her to budesonide, Pulmicort, because there had been limited studies showing that there had been a lower progression to the inflammatory stage with budesonide. And that was on the advice of the respiratory physician who was looking at my ultrasounds. Okay. So can we just pause? I have to quickly move to another room now, because background there, I've just been kicked out of the study because my wife has to start a meeting for actual paid work. So I'm in my kitchen, and my dog may well bark. So he's about to jump on my lap because it's where he sits. So where was I? I was talking about my daughter and her medication. So yeah, the advice of the respiratory physician was to start her on Pulmicort or budesonide, and then, sorry, he has to sit there, he won't move otherwise. So we started her on that, and she slept the following day about 14 hours. And then after that, apart from loss of taste and smell, she was pretty much asymptomatic. Then a few days after that, my youngest daughter, who's 10, she tested positive and she was completely asymptomatic. My middle daughter, who's 12, she returned 8 negative tests. And then after we were all better, we got the director of infectious diseases at Liverpool ordered some quantitative antibody studies for nucleocapsid and spike protein, and she didn't have any of them. Her bedroom's opposite ours.
Wow.
And so we're thinking either it's luck, or she had some sort of, more robust innate immunity, T-cell immunity, or she may have been exposed to a different coronavirus and had some cross immunity to this SARS coronavirus, just because, 2 of them have already caused just a common cold. We don't know, but she's all been Modernaed up, and she's got her Moderna vaccine done. And the others we won't do till 6 months after their onset of their disease. So I don't know if it's a good time to show some of the scans. Oh, right. So why was I scanning? Well, because I had the scanner, and as I've already spoke, that I had the butterfly and I had the mind ray, but I don't know how much you've looked into how to decontaminate an ultrasound after scanning someone with COVID. It's an extremely laborious process. Even the wheels of the trolley and everything is with bleach and then with Clinell wipes and all those sorts of things. So I left the really expensive machine in its bag the whole time, never touched it, and just used the butterfly. And this is not to promote butterfly per se, but other than to say that it's just easy to clean. So it's a sealed unit. So I had that, and I was using the iPad with it. And
so would you would have the plastic wrap over the probe, the wire, and the iPad?
I didn't.
Yep, just to the wire.
I didn't use the probe cover at all because I wasn't going to be taking the machine out of the house for weeks and weeks and weeks.
Ah, gotcha.
And then once I had taken it out, it was thoroughly cleaned and cleaned and cleaned again, and left to sit there for days. Because the virus will become inactive anyway after 2 days. But Clinell wipes will kill norovirus, so they'll kill this. So I mean, in my clinical settings, I only ever use it with a probe cover, but at home there wasn't any. I didn't have any. I would only have sandwich bags or something, which you'd be surprised that some radiology clinics just use sandwich bags. So I didn't. I just cleaned the probe itself, and so everything in the house was already. There's no point trying to clean it. To keep
the whole house with
it contaminated, because the whole house was swimming with it. So it just stayed in house, so to speak. So then it was quite happy that the IQ Plus had come out, so that it had the AI features with the auto labeling for the scanning protocol, which we'll probably go into. So I spoke to CISA, this respiratory physician, and she said, I want you to send me scans every day, and we'll see if it's getting worse or getting better, and I'll advise accordingly. So it was quite easy to scan myself, because it's fairly simple protocol to replicate, because there's only 2 scans on the back. There's one over just next to the scapula, and then you can just reach under and do above the diaphragm. I wouldn't have been able to do a middle section in the back, not in a way that I could replicate. I did get my daughter to do the first one on the back, and then I found that it was easier for me to do it. So I did one of those, and then Cissa would say, no, I want to get this image back again, or there's quite a bit more B lines than I'd like on this image. Can you send me that again? And so then she would look at that. So I sent them every day for myself, for my wife and my daughter for a week, and then we spaced it out a bit longer.
So this is a respiratory physician with a interest in point of care ultrasound.
Yeah.
I can't say I've come across many of them, but it must be growing in that field. Yeah.
I would think so. I mean, because traditionally we'd thought that lung ultrasound was rubbish because it's full of air, but now we know it's an artifact-based protocol, as Liechtenstein pointed out. And so there's a growing awareness of it. I mean, it's of limited use in respiratory medicine because you're not going to be looking at the parenchyma very much. But we know that there are people that are doing, ultrasound guided biopsies through bronchoscopies. So they'll ultrasound from the inside, and then they can look at it. I think it's more use in the point of emergency department setting for diagnosis. So you can see, have they got a viral pneumonia? Have they got a pneumothorax? Is there an effusion? And these things are quite easy to pick out. And so, it has much more use there. And I will just backtrack a bit. When we intubated some COVID patients, we had an ultrasound machine, just a Sonosite S2 wrapped up that stayed in the COVID theatre, and that was the COVID ultrasound. And so we would confirm lung sliding on both sides after intubation, because I'm not sticking anything in my ears in a COVID theatre.
Exactly.
So I'm not listening to their chest. So if you just confirm lung sliding on both sides, then you're pretty comfortable you're not endobronchial. So so there's an increasing awareness of it there. But in most cases in my theatre complex, no one else does it, except maybe in an emergency and an arrest to look at lung sliding. But even then, that might be if there's someone from ICUs down there who wants to look at it. I had a Met call in a theatre just on Monday, and the intensive care specialist said, have you got a transducer? So I pulled my machine out and we just checked lung sliding, because we were suspecting, because I'd tried a central line and was suspecting a pneumothorax, but it wasn't. So so there's an increasing awareness of it, but more among intensive care than anaesthetics. So I don't know if it's worth having a look at some of those scans from the home.
So you were scanning at home, and by remote, a respiratory physician was looking at these images. I mean, that's a pretty amazing setup.
Yeah, so I just clicked the share study, and it would share the entire series with her for each one. So I'd send her an email with a web link for each study, and then tell her what my symptoms were, what medications we were on, and then she'd review those until she wasn't worried at any point in time. And then, so every morning our routine is I'd do obs on everybody. I'd do a nursing round, and I'd get them out of bed, do some SATs, do a blood pressure and everything else, do a temperature, and then do a lung scan. And then a bit later in the day, somebody from the New South Wales Community Health Team would ring us up, and then I'd give them a report. The Children's Hospital was really quite interested, and they thought they didn't end up getting back to me. I think they got overwhelmed with the number of cases, but they were quite interested to see what it looked like on the child.
Well, let's see some images. Yeah.
So I've really just, because we don't get overwhelmed, I've got 2 images to show anything, and then it just got sort of improved from there. So I'm going to share my screen. Hang on.
You mentioned, you said your 14-year-old daughter, she had a bit of lethargy, but then sort of really recovered. She didn't have many respiratory symptoms.
That's right. So this is me, and now on this zone 3L, that's just in the left armpit, basically. So I'll just play it again. I can't get it to loop. So what you can see there, up around here, is a combination of 1 or 2 B lines plus more comet tails than anything else. And I see that a lot, and a lot higher density of those sorts of images in more severely ill patients in the intensive care unit. Although I saw none of this in the anterior segments of my own scans. They were just all A lines. I mean, this is mostly A lines, but you can see some of those things if I just loop over there. Whereas if you look at my daughter's scan.
So for you, your B lines were primarily gravity dependent near the base. Is that right?
Yeah, they're all posterolateral on most people. So this is my daughter's down on the right, under the right armpit. You see quite a few more changes there, all the way down. So there's some common tails, but also some frank V lines. And up around here, you can see these, you'll see there, so some pleural consolidation.
And this is in her mild phase of disease. That's right.
This is well, no, this is her worst phase when she was wheezy.
Okay. Yeah.
So, and then the next day after that, she was lethargic, and she actually got better as time went on. So I just saw those areas over the next few days waned. I mean, it's not worth showing them getting better and better and better, but
did it seem like the lung changes correlated with your degree of illness?
It's only 3 people.
Yeah.
So it's difficult to say. I mean, I'd like to say yes. I think yes, but really, it's not a very scientific analysis. So yes, but I don't know if it does for most people. So, but yeah, they did. And on day 4, I started to turn a corner, and then just had some light cold symptoms and just residual nasal tone of voice. Plus, I mean, the taste and smell is the same sort of as when you get this loss of taste or smell to drugs, which can react to any drug. It happens more commonly in anesthesia because we give them a bunch of drugs all at once. It kills off the cells, so you have to wait for cell turnover. So which is why taste comes back first, and then smell. So with taste, we got return of the basic tastes, bittersweet, salt, sour, and then more subtle tastes, and then smell takes 10 to 14 days. I mean, there are cases. I have a friend in the UK who still has very altered smell months after it.
Wow.
I had tinnitus for 3 months on the right ear, and after we thought we had completely recovered, both my daughter and my wife, when they went out for a jog, they had pleuritic chest pain anteriorly and then my wife had it most of the day for about a month. So that was an unexpected latent symptom.
Wow.
I never got that.
You mentioned like you had your daughter scanning you. Was that easy for her to pick up? Like, I'm thinking, imagine you had a household of no medicos. Do you think they could even monitor themselves with this sort of remote model that you had going?
It's possible, but they're not scanning an anaesthetist. So the fine tuning and the pickup and the angle and the capture, and like saying, no, that's not exactly what I want. Like, I think it seemed easy for me because I could coach her straight away. I think that, and we'll talk about this, if there is a role for ultrasound in COVID for early presentations, I think it would be better off training up somebody like a nurse practitioner or a physician's assistant where they exist in community centers, where in other countries such as Brazil or the Philippines, something where they've got access to hundreds of primary care patients in clinics all showing up, whereas we don't, in our model of care, have doctors physically seeing early COVID patients. And so and then you're able to access more data to see if there's any potential for stratifying potential morbidity from these, how many B lines in how many segments, and is this likely to need hospital admission later or not? We're not going to know that unless we get that data. I think that care in the home by families is fraught, and I think there'd be quite a lot of inconsistencies. I mean, and that's the reason why the model, for example, for echocardiography, the cardiologists don't commonly do their own scans. The sonographer does. And they interpret them. So it's a matter of getting consistency in capturing the images. I don't think you need a medical degree to learn that, but you do need to have some sort of insight into the anatomy so that they can know what they're looking at and what they're not looking at. So, and even after the second day, I didn't ask my daughter to do it. I just did it myself. But yeah, I don't really think that members of the public could be scanning themselves, but only situations where people have access to a lot of patients.
Yeah. So you guys recovered slowly, some residual symptoms, and then you found yourself back at work. So this is mid-2021, middle of the Delta surge, really, isn't it?
Yeah. So what was interesting, so once I came to work, minus the the gorgeous actress, well, minus the trophy actress ex-wife and the adopted kids from Cambodia. It was like Brad Pitt on World War Z. So, on that film when he's had the terminal disease.
I've never watched that film.
It's this zombie film where a virus in the book came from China, but in the film they wanted to sell it to communists, so it didn't come from anywhere. It's just a virus. It's a variant of rabies with an eight-hour incubation period, and all these people run around trying to bite everyone. So, but they run around this kid in Israel who has a terminal disease, and so he figured that they somehow can sense that someone's dying, and so they're not going to bite you. So Brad Pitt's character had himself inoculated with some tuberculosis or some sort of bacterium, and he had some sort of antidote because it's a film. And so he's walking out of this clinic where he'd got this stuff, and all the zombies are running around him. So I felt like that. So I volunteered for all the COVID shifts. I said, I'll go into ICU. I don't care if someone, and like if I intubated a severely autistic teenager who was COVID positive or SARS-CoV-2 positive, but didn't have any COVID disease. She'd already sent 2 nurses home by ripping off their PPE. And nobody really had an answer for what to do with me. She ripped off my PPE because it was all the same strain. And so obviously I took all the same precautions as everybody else, but I had that degree of confidence to be able to hold her down properly so I could get the ketamine into her, so I could get the tube into her. And she wasn't being intubated for COVID. She's being intubated for, they couldn't manage her, and she had to be transferred to another hospital, and she was ripping everyone's PPE off. So, so the other guy that I caught it from, and with gene sequenced, I caught it from him. And they didn't know.
So that was confirmed.
Yeah,
like you knew that exact guy. Wow.
So we were volunteering for all the COVID stuff because we could walk among them. So to speak.
Yeah.
So I did a lot of shifts in ICU at Campbelltown, Liverpool, and I did a lot of the COVID airway shifts overnight.
So you're an anaesthetist, primarily in operating theatre. You're coming into that ICU environment, and you're primarily as a proceduralist.
Yeah, well, there as a help, basically almost like a registrar, just to help to give them a load so they could focus. Because when you prone a patient, and I'll show you the scans of one patient that we proned, it's a lot of people and a lot of work. And one guy that he was so sick that when he was sitting there intubated, saturating at around 87, 88%, which is half of the course for COVID patients in ICU. We turned him over and his sats dropped with a good trace. I kid you not, 35%.
Talk us through like the proning. We have to extubate the patient at the time.
No. You have to control the tube.
So
you have to take the tube off the ventilator, turn them over, reconnect them, blow them up.
Got you. So for a minute or so, they're not getting that FiO2 of 100%, and you saw the sat drop to, did you say 35%?
Yeah, I mean, below 80%, it's not calibrated, but when it's a good trace and it below drops to that and they look purple, you don't disbelieve it. So it's something profoundly below 80% is all you can scientifically say because of the calibration. And some of the nurses who'd been in ICU a while were just casually, poking at buttons and doing stuff. And the intensivist and I just flashed a look at each other, like, let's just do nothing and wait for this 130 kilogram man to arrest prone. So, and then it went to 38, 42, 47%, 50. And I've never been so excited and happy to see sats of 60. I mean, normally you're puckering with sats of 60 in the operating theatre. You think my career's over, I'm going to have to call a band, But and then they gradually crept up to settle at around 89%, and then we're happy with that. So it's a lot of work. And then the same patient had that similar desaturation on intubation as well. This was a guy that was a truck driver. He didn't smoke. He had his vaccine, but he got the symptomatic the next day. So he clearly just had bad luck. He'd already been infected. And then he had a big load of spike, and then he got sick with the virus. So, so I think his inflammatory reaction might have been earlier than normal because he didn't increase this is me speculating now, increase the number of those antigens as gradually as might have been the case through replication alone, because he also had it through the vaccine as well. So, I mean, the vaccine is supposed to precipitate an inflammatory response. That's the point of it. but you don't normally give it to someone who's just been inoculated with the virus.
Yeah.
Like the day before or 2 days before. So that was bad luck for him.
Yeah.
I've got some scans of him. I don't know if that's a good time to show now.
Yeah, let's have a look.
So I'll go to his ICU admission. I'll just go to the next one. So it comes up as, yeah, so this is, hang on, that might be the wrong one.
So you're in the ICU, you've got some nice machines there probably, but you've also got your butterfly that you can slip into that plastic sock.
Yeah, so I used this is all butterfly, and I also got a completely watertight iPad case. So I run it under the tap and decontaminate it more than anything else has been decontaminated. So this is him. This is his 41-year-old, 130-kilogram man when he's first truck driver. When he first arrived, he's awake and prone. And I was just there putting an arterial line into him and getting him all sorted out. And then I said, can I scan your back? And so I scanned. This is all the 3 scans I'm showing you are under his left armpit. So you can see here, confluent B lines.
I can't see the image yet.
Oh, I'm not sharing. Hang on, let me share. That's why.
Did you?
I unshared before.
I was also distracted by thinking of how to do an outline in a prone patient.
Oh, it's not so hard.
I suppose I rotate the wrist around.
Yeah, you just go sideways. So I didn't get his wrist supine. I just did it sideways. So now can you see the screen?
Yes.
So this is lots of confluent B lines on this rib space, this rib space, this rib space, and it's just got quite a lot of fluid there. So he was awake. He was on high flow nasal cannula at about 40 liters a minute, and he was saturating at about 88, 89% on that. And he's awake, and he said, "Oh, I'm worried I'm not going to make it." I said, "Oh, don't be silly. You're not that old, and you don't smoke." And but that's still pretty nasty looking pattern there. So, wow. And that's sort of indicative of the subpleural consolidation here and here, and then you can see that coming through. Whereas you're hardly seeing maybe one or two, a few little A lines here from the pleura, but not much reverberation at all. Then
it looks like those sort of confluent B lines have essentially obliterated the A lines, huh? And that,
for the most part, yeah.
That zone, so that there you've labeled it zone 3L, and I know there's all these different zone systems floating around. This is the butterfly zone system, isn't it?
Yep. Yes. So the advantage of this is that you don't have to go and add text to them all. You just tap on a zone and it auto labels it for you.
Yep.
And it makes it very quick because you don't want to be fooling around. There's a lot of extra tissue up here because he's quite a large guy.
This is actually quite superior in the lung, isn't it? So
yes,
the COVID lung changes often come on as a very sort of patchy multi-lobar thing, don't they, with some spared areas. At this point, did he, can you remember, did he have any spared areas? Was this like one of the worst views you got on that day kind of thing?
This is one of the worst views. The worst posteriorly. I couldn't check his anterior views because he was prone, but his anterior views were better. I mean, I have them, but I didn't record them for this purposes. And if I show them on the screen, they'll reveal his identity, so I won't. What I'll show is so this is him prone, and then the next one is him prone, the same position, just after I proned him with that devastating desaturation. So this is same zone now, and you can see that pleural shred sign. It just looks monstrous. And then you see, I think the probe moves down, and you'll see another rib space down there with the changes more typical of the earlier scan. So I'll just flick that through that again. So you can see that there's not much movement there.
Wow. So, I mean, that's incredible. We see that pleural line and then that sort of step of, like you say, shred or subpleural consolidation, don't we?
Yeah, so it's called a shred sign. And as I was, it's tempting to think of it as it actually looking like you're looking at a visual image, and so because that's our bias, but it's, really a visual representation of sound. So I guess that's how Bat would see it. But it is not, obviously not actually shredded. What that's showing is that the sound waves are able to travel through these sections, and these sections are much better because it's subpleural consolidation. And his showed that. I've got some pretty feral looking scans as well from another patient where you see that basically the same sort of ultrasound as that, and very few black bits on the CT scan where the lung is spared.
And the COVID lung changes, when we look at the CTs, they're often at least starting peripherally, so which is a positive for us as sonographers. It means they're accessible, aren't they, for us?
Well, and that's where I'm hoping that if someone's able to get a lot more data, where you may see these early signs, and if they are shown to be able to risk stratify for morbidity, I don't know, but yeah, it is fortunate that you more likely will see them peripherally. Now I'll just show you his last one. So this is day 13, and now he's extubated, and he is on this one. He is supine.
This is day 24. This guy's been in the hospital over 3 weeks. Is that right?
Yeah. So this is in this 3L again, similar angle of image to the last scan. So it's much improved. You've got some sparing of the. You can see there's only like quite a few B lines, and still a bit of subpleural consolidation there on the shred sign, but it's not like it was that complete whiteout on the first scan, or that monstrous looking pattern where you even saw a small degree of hepatization of the lung with those consolidation areas. So I think the improvement is easy to see, except that the only caveat is this is I already know he's improved when I'm looking at the ultrasound. So the predictive value of that it remains to be questioned, and I think more expert people than me should be looking at that. Dr. Clark, I think her name is, in Queensland, and Sam Ord in Nepean, they're at a far better position to be making these sorts of pronouncements. But for my purposes, I think for diagnostic, if you see someone that comes into a primary care facility or an emergency department with these respiratory symptoms, can I see these signs? Can I not see these signs? So there's some good categorical data. I don't think they bear any influence at all on whether you intubate them. It's purely a clinical judgment. But they can just say, oh yeah, look, the images show how sick he was, but really how saturated he is how sick he is.
So I guess we're talking about the prognostic value in the COVID patient. From my perspective in emergency, we've got that benefit of, we're right at the start, we're doing a lot of diagnostics, and we can differentiate COVID from other things. That feels like one of the major benefits of lung ultrasound. And the example that sticks out is the patient who's very short of breath, hypoxic. If they don't have a COVID pneumonitis on a lung ultrasound, you can basically 100% say this patient does not have COVID. If they have A lines everywhere and they're hypoxic, it's not going to be COVID.
It's not as likely. No, I mean, it is an evolving disease, and different variants may have different presentations. They may have different affinities for pneumocytes. So, but I think it's more, you can say this is not a pneumothorax, or this is not a lobar bacterial pneumonia, or this is not an effusion or a hemothorax or something like that. So I'm not sure you can rule out COVID, but you can rule out other things.
In the emergency, where I guess we're notorious for being cowboys and a bit rushed, and throw on the probe and do this and that. What's so important about being protocolized, like using one of these zone systems? Can't we just have one or two looks and just be done with it?
Because you've got to compare apples with apples. So if you don't all have it doesn't all have to be shared, but there are a number of different zoning systems which suit different purposes. And if you don't have a shared understanding of what those zones are, you could be looking at two different things. I mean, even those 3 images I did, I had to be very careful to try and get the same rib space, and judge that from where that patient was, where his armpit hair ended, and all those sorts of signs where I could see. So to get that consistency from patient to patient, but also from scan to scan, or from study to study in the same patient, So I think it's important to get that sort of uniformity, and that's why I don't think it's appropriate for patients to be doing it who aren't otherwise trained. But if you could get people who could be trained in that image acquisition in clinics, such as certain nurses and physicians' assistants, then I think it's got some utility. And then I think protocols in general enable people to work at a level that exceeds that of their training. That's what protocols are for. I suppose emergency protocols also enable us to do something useful while we're waiting for our catecholamine levels to fall. It's true. You have a pilot. We've got MST protocols, pilot protocols. You've got drills to do. You're thinking what the hell's going on? Oh my God, they might die. But you're thinking, okay, what is the airway good? Is the breathing okay? Is the circulation? So, and at a slower pace, image acquisition drills, I think, perform the same function. So you can get this consistency across time and a consistency across the population for your images, and then we've got something to study.
Hey, you touching on lung sliding to confirm intubation, and then you've talked about art lines, you've talked about COVID for the lung. What in these COVID ICUs, what else, where is ultrasound really useful otherwise? Must be some echo going on, obviously.
Yeah, well, the intensivists do quite a lot of echoes. Usually there's one or two in each department. Some of them will have their DDU, some of them just have an interest. And there are protocols, at least at Liverpool, I know there's a protocol for lung ultrasound in COVID. And so, for example, they were using it to decide whether to give diuretics or not based on the number of B lines present.
Oh, wow.
And they'll be doing echoes. They'll be looking, at the general cardiac function, but in particular, you're looking at the right heart strain. So you look at any signs of pulmonary hypertension and any prognostic value with that. Again, it's more just because they're sick patients, and more sick patients these days are getting ultrasound, getting echoes and lung ultrasounds in ICU in general, but particularly with when I was working in Liverpool, they expanded to 6 ICUs. 4 of them were full of COVID patients.
Wow.
4 of them were on ECMO. So their PPE was really like their protocols and their regimens, they had people who were just paid to sit there and watch you put it on properly. It was really, really well done. And so there were quite a few people there who were getting scans, but it wasn't a consistent thing, not like I was doing at home with I'm going to scan every morning, because I'm not sure if they would get that much data from a daily lung scan in a patient who's already intubated, already in ICU, already on maximal treatment. So I think the B lines and diuretics and one other things it's really quite a new and evolving field, but certainly looking at their cardiac function is something quite relevant to that.
And the ECMO, of course.
Well, they get the cardiac anaesthetics people to come and help them put that in. So they'll do it under toe guidance and that sort of stuff. So
gastric ultrasound, intubation, but these are sick patients. They're going to get tubed. And airway ultrasound. Have you touched on that much?
I've done an airway ultrasound once, and then it was just for a patient who had a previous report saying that she had some tracheal stenosis on a previous operation. So, and they said they couldn't pass the tube very well, so it was fairly high. So I did a scan, and then I looked at it and said, look, I can't make a call on this. I'm not a sonographer, and I don't think that we make final calls on a lung on a tracheal scan. But so I sent her for MRI, and there was no stenosis. I couldn't see stenosis, so I gave myself a pat on the back. That was just luck. But some people I have heard in the States are using lung ultrasound in real time to confirm tracheal placement for rapid sequence. So they could use the lung ultrasound to provide the backwards, upwards, rightwards pressure, as well as showing that the cuff of the tube passed through.
Oh, wow. Yeah.
Again, I wonder in lot whether that's, hey, there's this cool thing I can do with this ultrasound scan. Or how useful it is. And so gastric scan has become in a sense was like that too, because people have been arguing, well, if you're going to do rapid sequence anyway, what's the difference? Well, then you could say that about gaining knowledge about a lot of scenarios where it's not going to change your action terribly much. It's like if you see that someone's, yes, it's an acute abdomen, but if you also see that their stomach looks like a haggis and it's just chock full, then you might do just something differently. If you see a starry sky in their stomach, so there's a lot of food and food floating around in fluid, if the patient's up to it, you might be able to get a nasogastric tube in, like you could with a baby for a pyloric stenosis operation. You might sit them up at 30 degrees for their intubation. I mean, I do for rapid sequence anyway, but you'd be much more conscious of that. Or if you, I mean, so I haven't got to doing it yet, but I was going to sort of starting to formulate a plan, because I've been in contact with the anaesthetist in Toronto who runs the gastricultrasound.org website, that I did want to do a scanning stomachs before induction, but that was the administrators and surgeons would find that fraught, because if I see something in their stomach, I'll cancel them, and then it throws everything out. So I mean, there was a study in Korea of 137 people for elective lap chole, and they found that 13 of them had contents in their stomach, 8 of them had food in their stomach. And so, but if you cancel them, bring them back another day, what's to say they won't still have food in the stomach that time? Essentially, all you can do is keep them in there for hours and hours and scan them every hour and then do the case. And so that wasn't going to fly as a study. So we looked at potentially scanning people after they've had their whatever airway we would normally use for them for their operation, be it a laryngeal mask or a tube. And if we find contents, and if we change our subsequent management, so if we sit them up for their extubation, or if we extubate them in theatre with suction ready, or we do anything different, if we put a gastric tube down a patient that's had a tube, then that could be a surrogate for having cancelled them if we saw them preoperatively. Some things I'm not sure that they want to know. And what it leads down to is well, if this number of patients at 6 hours are not actually, have contents in their stomachs, and given the lowish rate of reflux and aspiration, how much does it really matter anyway? Or how many patients are actually lying and they're not fasted? So we don't know. I mean, there are ways. There is a surgeon in Salisbury in the United Kingdom who does co-oximetry on his spinal patients and cancels them if they've smoked, even if they swear till they're blue in the face, that they haven't smoked. And he says, well, you're blue in the face because you in fact have smoked, and so you're not getting a spine operation. So that's easy to do in the NHS, where try doing that in the private. So.
Well, I definitely think gastric ultrasound has a big potential to disrupt the whole fasting paradigm.
Well, and I had an ECT patient at 5:30 in the morning, because I do a private list once a month. And this patient who was, was an ECT patient, so he's not too sure. He said, I'm not sure if I had something to eat at 2 o'clock in the morning. I can't remember. And I said, okay, roll over. So I scanned him and I saw a really good, really textbook target sign of an empty stomach. I said,
so it's sort of like the stomach's clamped down, is that right?
Yeah, well, you wait for peristalsis and it'll clamp all the way down, and then you see a black ring around it. And then that's an empty stomach. And you have to get that, and you have to confirm that in the right lateral decubitus position as well, because you might not see it if they're supine. So you're pointing their stomach down, so it's like a funnel. So anything that's there, as long as it's below, I think it's 1.6 mils per kilo, then that's considered functional fluid accumulation and functionally empty. So I saw that sign and I couldn't see anything. And so you measure the diameter of it, even though you see that sign. And so you'll get, there's an Excel chart that works for BMIs up to around 35 or 40, I think. So I confirmed there was nothing in there, and we did the scan. I mean, it turns out he hadn't, he just had some, false memory. But so there's some utility for that. But I think in patients for emergencies, I scan their stomachs anyway, so I get an indication of when people say, because we know that with you get the level of sluggish bowel motion with patients who've got abdominal pathology, in particular like appendicitis, or if they've had opiates. And it's interesting to see how much people have left. It's also interesting to see people who you trust their word that they that they have eaten. Like, I've had patients that have been 5 hours fasted and their stomach's still empty. So the 6 hours is just a ballpark figure that you're hoping catches most people. And I think the American ASA say 8 hours for heavily proteinaceous meals. So yeah, it's an evolving field, but like because of the potential for cancelling lists or cancelling cases on lists, there will be some pushback.
Yeah. Hey, well, this has been really incredible to hear your perspective and experiences. If you now reflect back to when you were a novice learner, I guess think of all the novices starting now mid-pandemic. The educational resources are not there as much during COVID surges. We can't go and do the workshops when there's a big surge going on. What do you think the POCUS community needs to do to really broaden the use of lung ultrasound now?
Well, talks like this, and I think that the educational facilities, so the Butterfly produced one, but a number of other bodies have produced some online learning activities. And so the Ultrasound podcast is another good one. There's another one, the ACRAC podcast, which is Anesthesia and Critical Care podcast. There's a guy from Johns Hopkins. And so people talking about how useful it can be, and then those training programs. I think there's 2 books, volume 1 and 2, on bedside ultrasound that are produced by these American physicians who run the Ultrasound podcast. I can't remember their names, but they're on Apple Books. You probably got them yourself, I'm not sure. But the training, I think, that will be the way, is to talk about it more, have all these online things, have short episodes and some studies. I mean, and people can upload their images for others to look at. Butterfly's got a gallery of COVID ultrasounds to look at, so then people can get more of an idea. And if they, like you say, there's not many opportunities for people to go around to the bedside and teach. But so the videos could also be of people doing them, not just of scans.
It's about that thing that we're missing out on, is that tactile, hand-eye coordination. Just have that hand positioning. It's so hard to convey unless you're there in person, isn't it?
Yeah, well, one tip that I found, which was given to me by a cardiologist, is make sure you anchor your probe with another finger, so that because particularly with pocket probes, that the batteries contained in them, they're quite heavy, and you'll get a lot of drift. And so if you find that you just strut, put it, have your probe there and strut one finger out onto the skin, and then so you anchor. So the probe's there and your finger's just there anchoring that, and then you can get a much more consistent image, and you won't just get that drift that you'll think, then you have to go back up again. Particularly if you go over a rib, you drift, and then it goes, it goes to the next spot, and you have to find that spot again. And that was something that, and just little micro movements like that, just in little circles, which is more useful for cardiac. If you want to get a particular angle right, you can get. It's quite amazing how those little movements will improve things.
I think we really need to stretch our skill at, verbally and with images, conveying these sort of micro skills, isn't it? Really. Look, I want to ask something personal. Like, when you saw the truck driver, you had personally just had COVID. Do you feel like you're a better clinician now that you've had COVID yourself, and you can relate that to patients?
The patients love it. Yeah, they really relate to that. I mean, what's interesting is that, like I told him, I said, look, my fault, except one miraculous freakish daughter, my whole family had COVID, and just saying his age and what he was, I'd been updating my wife, and we're so thrilled that you're extubated and sitting in bed. Wow. And he was misty-eyed. He said, this family I don't even know were wondering how well I was doing when I was unconscious. And knowing that we'd been not through what he's been through, but we'd had the same virus. And I said, well, that's why we come to work, buddy, because we do care about you. And I think that it adds to it. I mean, that's not to say that a doctor who hasn't had COVID is not as empathetic or doesn't care as much, but it makes it easier to relate. And I said, I had that short of breath. It went away when I got up. And I said, you taste, sense, smell. This might take this long. It might take longer. And then you tell fart jokes, and they can relate to that. And so, it certainly does. And so I also did a few, before the ICU shift really fired up, I volunteered to do some of the hospital and the home phone call sessions. And so I was just a phone a friend on the line, and they're home stuck with their, there was one person that she was old and she was lucky that her husband deteriorated because then he went to hospital and she could cope better.
Oh.
So there's no one else to talk to. And so having someone who's a doctor who's also had it, they found that quite comforting and said as much when I called. So yeah, I think it did. I mean, I think, but I don't want to take that too far. You remember that awful film from the 90s or 80s called The Doctor? And there was
again, Michael, I do not know that one.
Well, have a few gins and then watch this film, because you want to throw the remote at the telly, because it's made by a bunch of lefty lovies who think that we're all, Dickensian Scrooges who want to kick people on the way into the building because their Visa cards are maxed out. And so there's this doctor who's got no empathy and he treats people like garbage, and then he gets throat cancer and goes through this ordeal with a surgeon who was like he was. And there's a patient there who had a negligence thing and he's laughing about him. And then so when he's had this epiphany, it's like any spoiled child who discovers being nice to people and then evangelizes it to everybody else as if no one else thought of it. and he subjects all his med students to enemas so they get some insight. It's like, how arrogant and narcissistic is that, to think that no one else could have empathy unless you get throat cancer. So I don't want people to think that doctors can't display the same level of empathy to patients and think, well, you haven't had COVID, what would you know? So, well, it's only my vocational life. It's only the rest of my career. It's only what I've devoted myself to. So yes, it helps. But it's not it's not all there is to it. It's not the only thing that can the empathy.
Well, yeah, I feel like hearing you share your story has it's made me much better equipped to meet the COVID patients I'm going to see in the future. Do you have any last word for our viewers? Many of them are yet to really see a big surge of COVID patients. They're going to get out there with their lung ultrasounds. Any final words to share with them?
Try not to get in the way. It is still a diplomatic game. And so you don't want to, even though you do have to get numbers up, you don't want to look like you're there to get numbers up for your scans. So try not to look like you're just there as a sonographic voyeur, and really find ways to integrate that into their care and acquaint yourself with your local hospital's protocol on how many B-lines for diuretic, for example, if they're intubated, or do them for a reason. I mean, that applies to any investigation that we do for patients, but find the reasons to do it. And then when you're doing that, there's an increased tolerance for, oh, and by the way, wasn't this interesting as well, that you did a scan but didn't have to do it, but you're also confirming that so you might, if you're involved in an intubation, you might look at the lung sliding, and then when you're looking at your lung sliding, you say, look, there's all these B-lines and shred sign and everything else. And then it's like, do you mind if I just scan the rest of him? Yeah, go ahead. And I found them very welcoming, but it's particularly if you are doing these shifts in units you don't normally work in, that you're a guest and you're there to help them, not to parasite, not as a parasite to just leech scans off them. And so I found that, after I put a central line in somebody, I'd just stay there and just switch transducers and scan the rest of them. And then make yourself useful, and then make the whole protocol useful, and then they'll be more receptive.
Wise words, Stacey. Wow, what a talk.
Wow, indeed. Thank you so much, Michael, for taking the time to genuinely and thoroughly share your COVID journey and your scanning journey with us. It's just, it was entertaining, it was inspiring, it was informative. There's just a huge amount of value in your story and the sharing of that for our POCUS community. So I'm really grateful. Thanks on behalf of eMugs and our POCUS enthusiasts. Really appreciate it.
I was happy to do it. Thank you very much for having me.
Yeah, no, absolute pleasure. And Jono, thank you for your fabulous facilitation of the discussion. It's always great to have your voice and your face at eMugs events. I just want to briefly share this email address for anyone interested in finding out more about Butterfly. Obviously, the Butterfly featured in the journey and was a great tool for you, Michael. So thanks everybody for your time. And Michael and John, I will see you down the line. I think we'll make that a wrap. Thanks very much, guys. Bye for now.
Cheers. Thanks.
See you later.